Okay. All right. Excuse me. I made the comment about Dr. Walby, and I just wanted to say this is a personal comment. I was the summer I was 17, going to be 18. I was trying to decide what I was going to major on in college, and I was at my grandmother's house, and her new husband didn't like me, and he didn't talk to me too much. She had been widowed and she got remarried. So there I was, 17-year-old boy with nothing to do except push-ups, sit-ups, go jogging, and watch old TV reruns, right? So I'm watching, and Marcus Welby was such a good guy. One, he's so smart, but he's so kind. And so I was praying, so God, what do you want me to do in college? And after I'm watching Marcus Welby for 3 or 4 days, I thought, well, you could be a doctor. You were a pretty good high school student. You're pretty good at that kind of stuff. You could do that. And I prayed, Lord, if this is what you want me to do, say, show me. And I kind of had this feeling that he's saying, yeah, go ahead. But I didn't really feel real sure, so I kept praying. And about the third day, I came across this passage, and I can't even remember where it is, but it was like, I'm not going to tell you again. I already told you. So I went to college, and I was pre-med, but I still wasn't sure, so I was pre-med biology education. But after the second year, I thought, the Lord's saying, go ahead and try to go to med school. But Marcus Welby was my inspiration. And the reason I bring him up again is because a lot of what we're going to talk about is just the kind of thing Marcus might have talked with his patients about, right? This is common sense. Any good general nurse practitioner who loves her patients knows all of this stuff, right? But it still helps to think about it out loud again, because sometimes we kind of forget some of the things. So the first part here, we need to go back a slide. Let's see. I guess you're on the right slide. Yeah, you are. This is an interesting statement. The best interest of the patient is the only interest to be considered. How many of you believe that to be true? Well, the answer is, yeah, there's some truth in that. But that's not all truth, right? I would say the best interest of the patient is probably one of the most important interests to be considered. But the patient lives within a community, within relationship with a lot of other people. And I think to say, I'm not going to put the interest of the insurance company ahead of the patient. Sure, don't do that. But what about the wife? What about the children? So I think there's a bigger thing. And the next thing is, how do you define best interest? The ethics mantra that came out of Georgetown was now I'm blanking on the four I want to go with, but it's the authority of the patient itself, and then benevolence for the patient, and then non-malevolence, and then justice, right? But even then, when you get into benevolence, what do you really mean? So if the patient comes in, it's the authority of the patient to make their own decisions is the first one. Anyway, if the patient comes in and says, well, I thought it over, and I need those morning after pills because I'm a graduate student and now is not a good time to have a baby. Is it the best interest of the patient to honor her request? And I would say absolutely not. But that gets into a whole long discussion. So how do you define best interest gets to be complicated. Doesn't care include more than just the patient? Sure. There's a movement within a lot of medicine that, especially from non-physicians, but among physicians as well, that if the patient wants it and it's not illegal, they deserve it, right? So that kind of makes the physician or the healthcare professional just a technician, right? They're just doing whatever the patient demands. I want my burger medium well, not rare. I want my birth control pills right now, even though she's 13. You know, so I am strongly against this. The patient can refuse treatments. For instance, the situation that our sister brought up where her husband is a brilliant man, but he doesn't want to do the next thing. Well, he can refuse, and you can't make him, but you can try to convince him. There's a difference between coercion and persuasion, right? Sometimes it's a thin line, but persuasion, I'm all for persuasion if it's appropriate. Coercion, we need to leave to somebody else. But the best care of the patient begins with caring for the patient, okay? So a few years back, I had a patient that came in. She clearly met the criteria for the diagnosis of multiple sclerosis. Okay, and we already had like 6 or 8, well, this is a while back, so we probably already had 3 reasonable drugs for multiple sclerosis. And she said, no, I read about them, I don't want any of them. This is what I want. And she told me something, it was like, there's no indication, there's no FDA study, there's nobody that says that this is a good treatment. And she said, but I've read about it, and that's what I want. And I said, I don't prescribe things that I don't know will be helpful or at least non-injurious. And I can't say that about this patient. And she tried to argue with me for about 10 minutes, but I just said, I'm not going there. Anyway, so those are some of the caveats as I begin to think about this second part. Okay, then moving on to the next slide. Here are some of the biggest issues that I think of as far as dealing with the patient and the family and dementia. There are certainly others. If you notice, I crossed out medical assistance in dying. I'm an absolute firm believer that is never appropriate, period. Okay? If you want to lobby in your state legislature for different position because you believe differently, I'm not going to stop you, but I've written blogs about it and I've talked to people about it. I'm absolutely dead set against it. I'm very unhappy that Canada has legalized this and a number of states have legalized it. In case after case where they supposedly set up caveats for you have to do it this way and this way, it's a slippery slope. It doesn't work. And pretty soon, I don't know, I'm losing this thing here. Pretty soon the exclusionary criteria are not being met and the reporting on it is crazy. And I don't think a healthcare professional should ever be involved in this. So that's the end of that discussion. And if you want to go to a different place and hear the arguments for it, that's fine. But I don't think there are any good arguments for it. Okay. Anyway, we get into safety issues, competence, which we'll talk about, wills, advanced directives, palliative care versus hospice, and then community court support, church support. The safety issues. I practiced for 30 years in central Illinois. And Illinois is an interesting state because you have Cook County and the collar counties up here, and they are all one kind of, they're all Democrats. I mean, you know, year after year they vote Democrat. And then you have the rest of the state, which is Republican. And it's largely rural, and it's largely farmers. And what does every farmer have in their house? They have guns, right? Yeah, and for good reason. Many counties downstate cancel classes for the first 2 days of deer season. They just say, well, the absenteeism will be so high anyway, we might as well cancel. So you have to have those discussions. There are some questions that show up on some healthcare screenings. Do you have a gun in your house? Is it locked up? Is it in a safe place? Do the children have access to it? But a lot of gun violence, even though the news makes a big deal about crazy people who go and kill 10 people at a time. The vast majority of gun deaths are in the home with a gun that was owned in the home. So anyway, you got to have that discussion. Another big safety issue is supervision. And this gets back to the will of the person with dementia. And since dementia has multiple stages, when they're just very, very mildly demented, there are some stages where they talk about 6 or 7 different stages. The bottom line is, on any given patient, the stage could vary from day to day, depending upon how much sleep they got. Did they get a UTI? Did they have a pneumonia? Did they take a Benadryl? So I don't find those stages really helpful except for research. But the bottom line is, when somebody has mild, very mild dementia, you don't want to limit their whole life. And we were talking in the other room about taking away the keys or taking away the checkbook. I think there are a lot of intermediate steps. For instance, if mom has been the one that does the checks and now they're all bouncing, maybe it's time for one of the adult kids to come by once a month and go over the checkbook with mom. Don't take it away from her tonight, right? Because she bounced the check the second time. But you can incrementally these things. Same with driving. The daughter says, Dad's not safe driving. Do you just take the keys away? That would be crazy, wouldn't it? You don't really have any proof of that. So there are a number of things you can do. You get other people to tell you, is Dad safe driving? And if 5 of the other siblings all say, Martha's a worrywart, Dad's fine, then maybe you don't do anything, right? But if 2 of the other siblings say, yeah, I think Martha's got a point, what could you do about it? Well, you could incrementalize things. You could talk to him and see if he thinks he's unsafe. He may say, yes, Martha's right. I shouldn't keep driving. But you might say, why don't we start, no more nighttime driving, that's dangerous anyway. No more freeway driving. No more driving in bad weather, okay? Or another very legitimate option is, what if we had a driver evaluation, an occupational therapist with special certification in driver safety, if he took you for a ride and see what you think, right? And what is she going to say? I mean, is he going to say, he's going to say, forget it, I don't need that. Well, he might. But if you say, we're just trying to protect you and your grandchildren and your wife and the kids and the other people in your town, what does it hurt? Why don't we just have the driver talk to you? He doesn't always say yes or no. A lot of times he gives us guidelines. And I use that technique, and it actually worked the vast majority of times. And a lot of times the answers I would get back from the OT was, I think she's pretty safe. Or, I don't think she should drive at night anymore. Or, I don't think she should drive on the interstate anymore. And I found that very helpful, because then Martha's not the bad daughter, right? Martha's just a caring person. It was a legitimate, objective decision that limited things. What about getting lost? One of my neighbors actually played Division I basketball, and he was a successful high school coach for a bunch of years, but now he's 80 and he has dementia. And he didn't tell his wife, and he just got on his electric bicycle and he just disappeared, right? And 20 minutes later he calls and he says, can you come pick me up? He doesn't even really quite know where he's at. Well, he's getting lost. But especially if people are getting lost in familiar territory, they get lost in their own home, this is a big deal. Okay, competence. Competence is different than decisional capacity, and we'll talk about that a little later, but you have to think, is this person really safe to do financial things, make big decisions for the family? We'll talk about that. Palliative care versus hospice. It's an old statistic, and I'm sure I'll misquote it, but it was, yes?
Yeah, I have a question. So I'm a internal medicine
Yes.
So we see a lot of people who come in and they just, for whatever reason, are living on their own for a very long time, and by the time I see them, they've fallen, they've been on the ground for a day, they have rhabdo, and I've always kind of thought of it as they can stay living on their own, or they go to a home, but I never really have a good solution for like an intermediate sort of supervision, especially if there isn't family around, and some of the family members can be really good about, I call mom every day and I see, but how have you sort of navigated that when there's an insistence to live on your own?
Yeah, the question is, you have a patient come in who is clearly at risk to falling, and he lives by himself. He doesn't have family connection. And what do you do about it? Uh, you can't force him to go to a nursing home. You could, in certain situations, I used social workers. We had a social worker that was assigned to the neuro clinic, and sometimes I could get her involved, and maybe you could just have a whole discussion with him and scope out all available resources. Even just having a life alert is one good step. Or if he's embarrassed about that, getting him a smart watch that could alert somebody. We run this fine line. You don't have the right to force people to do things that make sense just because they make sense. But on the other hand, if they're a danger specifically to others, we allow a lot of latitude for them being kind of dangerous to themselves. How many of you always drive 2 miles per hour under the speed limit? Raise your hand. Oh, I didn't see any hands here. It's like, well, we probably should, right? Usain Bolt went on national television. He said, "I'm the fastest man in the world, but I always drive 2 miles per hour under the speed limit." You know? uh, Maybe we should, but we don't. So it's tough. But I really think engaging other helpful professionals can be so important. One thing that was actually one of the most fun things I did as a neurologist was I ran the MDA clinic, Muscular Dystrophy Association clinic. I'm an adult neurologist, and a lot of those people, besides the ones with ALS uh, or HMSN1 or some of the other neuropathies, they had childhood diseases and they were getting worse. Uh, But one thing I loved about that clinic was we had a social worker, we had a dietitian, and we had other resources, a pulmonologist, we had access to cardiology. A team approach for some of those people can be really helpful. And as a general internist, you can, you in the right setting, you could conceivably get your little web of connections around you that help you do that right. Uh, I was in a large multi-specialty group practice, and I would go away to some conference at some cool place, New York City or Seattle or somewhere, and here I am in the middle of the Corn Belt, and I'm thinking maybe I should go somewhere else. And then it would dawn on me: I know my neurosurgeons, I know my neuropsychologists, I know my neuroradiologists, I know my psychiatrists, I know all the pediatric specialists here, and I just pick up the phone and call them. And I don't put in a referral for them to go see. I just say, "Hey Larry, this is Bob. I got a patient. What do you think? Will you see him next week?" You know. So those kinds of informal connections can be very helpful. I hope that that is still true by the time you're actively in practice. But those kinds of collegial connections can really go a long way to helping your patients. Yes. Yeah, her comment was she worked in home health care, and a home health care referral could be very beneficial. Absolutely. Absolutely. Siblings. You mentioned didn't have any family connections, but siblings can sometimes be helpful. Daughters, sons, whatever. But
involve a local church pastor with church members?
Yes. Unfortunately, the results have been somewhat mixed. I had one lady that clearly had a functional neurological disorder, and her pastor came in and was kind of screaming in my face. So it's been mixed. But I've had other times where I've said, what would you think about counseling with your pastor? Or does your church have a pastoral counseling wing to it? And I've tried to refer people in that direction. And sometimes that's very beneficial. So one thing I loved about neuro is I knew patients for a long period of time, and you look for faith flags. And if they said they were very involved in the local Baptist church or whatever, and I knew the local Baptist church, I could say, well, Pastor Freddie might love to talk to you about this, that kind of thing. Community support and church support. Okay, so let's talk about supervision again. When is it safe to leave a loved one alone? When is it safe to leave a loved one with small children? Okay. Kitchen stoves, choppers, grinders, open fires, yard machinery, all kinds. There's danger lurking around every corner. It sounds pretty paranoid, doesn't it? But the point is, yeah, life is full of danger, and you need to be aware of that. I had a 50-year-old grandmother, and her daughter wouldn't let her hold the baby anymore. But the daughter was actually right, because the patient was beginning to lose arm strength and balance. And as she's walking around holding the baby, this is dangerous, right? So you have to say, maybe your daughter's got a point here. What about if you're sitting down and you have pillows on both sides of you? Would it be appropriate for her to put the baby in your arms? Yeah, sure. Open fires, nighttime roaming. Oh, this is a big one. And the Braves brought this up a little bit, but there are different solutions to that. You can put the locks way up high so they can't reach it. That's one thing. You can ring doorbells, different things like that. But yeah, sometimes it's tough. And sometimes you just have to say, maybe we'll hire a nighttime sitter. That's a tough one. Okay, this next one is very complicated. Who should quit or be asked to quit work? Okay, so I mentioned to somebody that I haven't been a prolific author, but I've written some blogs. I write blogs for the CMDA, among other things. And I wrote a blog a while back, and I thought it was a pretty benign blog, right? The blog just said, should we think about making some kind of mandatory retesting for physicians over a certain age? And that was the whole question. I didn't say, if you're 70, you turn in your license. No, nothing like that. In fact, we had some great doctors who were in their mid-70s, so you wouldn't do that. One person wrote back in and said, that's a thoughtful blog, thank you. Another person wrote in and said, I can't believe that the CMDA would allow this type of thing. I am withdrawing my membership from the CMDA, effective immediately. Well, actually, I was reacting to Stanford and a couple major hospital systems were beginning to institute mandatory recognitive training. And for a surgeon, it wouldn't be good enough to do recognitive training. You'd have to do some kind of manual training, or rechecking too, right? We lost a neurosurgeon a number of years ago because his essential tremor had gotten worse over time. He wasn't really good at doing neurosurgery with that kind of tremor anymore. So, but this is very complicated, and it involves a lot of people. I think the bottom line is, any job where the other's safety is at risk ought to prompt some kind of thoughtful discussion about it, right? So I saw one woman who was only 63, I think. It seems so young to me now. She was only 63. She was a kindergarten teacher. And she came in, but her sister said, I think she's not doing so well. I think there's some issues. We did some formal neuropsych testing on her because she was so young. I don't usually order a full neuropsych battery on anybody who's 75 with diabetes and old strokes. I don't do all that. But she was only 63, right? She came up, she was clearly demented, and yet she was functioning full time as a kindergarten teacher. Well, she was in her little niche, right? She was right there. Everything was under control. She'd done the same thing with kids that age forever. But uh, we got a full diagnosis. She got on disability. Any job employing firearms, cops, it's a little bit tongue in cheek, but not really. Politicians. Uh, yeah, I mean, this I don't make political statements in public like this, right? It's not my job. But early on in Biden's second term, I just said, the guy's demented. You know, get him out of there. He can't do no. And then sure enough, there was kind of this big cover up. And now that he's out of office, a lot of those people are saying, yeah, we knew it. Yeah. Anyway, many people are reluctant to quit, tied to their self-interest, sometimes abetted by others. Now, again, I'm not taking a personal slam against Biden, but if you think about that, there were people that stood to benefit by him staying in office. His wife, among many others, but it doesn't matter, right? It's like when I'm treating somebody who has a seizure, or when I was, I mean, I recently retired, and I say, you're having frequent seizures, you really can't be driving. And they say, well, I have to drive because my job is 30 minutes away. You say, well, you have to find another way to get to your job. You can't be driving. Well, I have to drive because my wife doesn't work and I'm the only one that can work and our kids have to eat. And the answer is, you have to find another way. So anyway, air traffic controllers, of course, pilots, bus drivers, law officers. So a lot of people there. Gun safety, we talked about. Certain populations are at higher risk. Now here's this thing again. Somebody's mildly demented. According to some of the stagings, there are seven stages. Some say 6, some say 3. But then the 7th stage way of looking at things, stage 1 is no evident problem, right? So you get somebody that comes in and you think, yeah, they got some mild cognitive impairment and they're probably stage 1, but their main hobby is going to the shooting range, right? You're going to take their gun away? Well, I don't think so. But you're going to have a thoughtful discussion about it, all right? So that's gun safety. We can move on. Wills and advance directives. Now this one is funny, but it's not funny, right? You have some piece of furniture in your house and you're getting demented and you have 2 granddaughters that both want the piece of furniture when you die. What do you do about it? Well, you don't wait till you're dead and then everybody else has to sort it out with these 2 siblings, right? You try to make some of those decisions in advance. Again, it's a personal situation. My mom died and she's a retired missionary and she had a total of like $5,000 to her name, something like that. And I had 3 siblings and I said, what the heck, you guys can have the money. We don't need our share of $5,000, right? You can deal with that. And my older brother said, yeah, we don't need it either. We'll let the other 2 younger siblings, they can split up what's left. But he didn't ask his wife. And when she found out that he had waived his right to 1/3 of $5,000, she went through the roof. She was very unhappy. So even small things like that need to be clarified. Okay. Power of attorney for healthcare. So this is not the lecture that our attorney gave us today. That was on power of attorney. This is power of attorney for healthcare. Okay. Living wills aren't all that helpful because they basically say, don't put me on a ventilator. You know, they're that kind of thing. But a power of attorney for healthcare, I choose you to be my decider because I trust your judgment and I've talked to you about it. Okay, that's a big key. Uh, it's not good enough to say, I trust your judgment. It has to be, and I've talked to you about it. Because sometimes people think they know what the other person would want, right? And they don't. Perfect example, this guy came in and he said, I know what Larry would want. He made me his power of attorney for healthcare. He wouldn't want you to go any further with, he's sick enough right now and he had a brain bleed and just comfort care only. Well, it turned out that wasn't a decision that we had to make because he was on the vent and he was doing okay and he was coming off the vent. And so I said, okay, just we'll watch how things go. We won't get real aggressive here. Lo and behold, he got a heck of a lot better. 5 days later, he's off the vent. He's up sitting, talking. We discussed it with him. And he said, what? You were going to let me die? He was so upset. And the guy said, well, you said that day when, after we were at McNally's, you said you would never want to live like that. When you saw the small bus go by with the kids with the handicaps, he said, we each had 6 beers. And we came out, and I made an asinine comment, and you're basing your judgments on that? No, it has to be a real discussion, right? And I'm going to get to one called 5 Wishes, which is very important. Anyway, you have to have a real discussion, and it has to be specific. But the other thing is, this came up in, I'm forgetting her name now, but a big case that came up, and they said, well, she talked to us about it when we were watching a movie. But the movie had been a number of years earlier. Okay, does that count? No. If the person said to me, we talked about it last week because we were reminiscing about Uncle Harry who was stuck on the ventilator for 3 months, and she told me last week this is how she felt. Well, then I would listen to the power of attorney for healthcare. But if they can't say something fairly specific, it's not good enough to say, I know how they would feel. You have to move on. Let's go to 5 Wishes. This is an important one. You can order this book offline. There's the website. And I really like this because it includes a lot of the things that our attorney friend talked to us about. Who will decide for me? Medical treatments desired or refused. How comfortable do I want to be? Now, a number of years ago, when I was doing my bioethics grad school, one of the speakers said, there's no pain that we can't solve. And my response to that was, that's not true. You can put somebody under anesthesia and you'll get rid of their pain. But some pain, you may just, it's on a continuum, right? How awake do you want to be versus how little pain do you want to have? And sometimes you say, I'll have a little pain, but I want to be awake. Okay, this is a very personal anecdote, but my wife was dying of ovarian cancer, and she had a rough day, and so we gave her a little more morphine the next day because she'd had a rough day. And I told her about it. I said, I think we need to talk to the palliativist, and we're going to bump that up just a tad. Is that cool? She said, yeah, I'm in a lot of pain. Well, she slept the rest of the day. She slept most of the next day. She woke up. She said, what happened to the day? And I said, well, you slept, you weren't in pain. And she said, I don't want to sleep away my last few days here, So you have to weigh that. What I want my loved ones to know, and I got another slide on that one, which we'll get to in a minute. How do I want to be treated? We went over the 5 wishes with my mother-in-law, who's in hospice right now. And she said very specifically, I don't want anyone to come up and pat my head. She said, that just irritates me so much. What, it's like I'm a puppy or a kitty cat or something? So I'm glad we asked her. So when I visit her now and I say goodbye, I put my hand on her shoulder, I kiss her forehead, I don't pat her head. Okay? And when she's too sick to tell us, I'll know, don't pat her head. Okay. I like this document. You may be able to download this free, but if not, it's just a few bucks. And it walks the family through the discussion with the patient, and you really get their wishes. And especially, what do I want my loved ones to know? Let's go to the next slide. Let's go to the next slide, and then we'll come back to this one.
I do have a question about that.
Yeah.
It's okay. So you gave a situation where the guy has a brain bleed, and the guy says, "Oh, just keep him comfortable," and then he unexpectedly gets better and wakes up. But what we see far more common is patients who have a brain bleed or some other, bad, their cardiac arrest on arrival, they're just totally out of it, severe anoxic injuries, other problems. And we really think the prognosis is 0 or horrible, but the family says, "Oh, do everything. Put them on dialysis, trach them, peg them, everything." So we see that more often.
Yeah.
How do we work through that? Because quite frankly, I wouldn't want that for me.
Sure.
But we deal with these families who feel like some miracle is probably going to happen. And as a believer, I like to think maybe a miracle could happen.
Yeah.
Probably won't.
Yeah.
I just say that.
Yeah.
Okay. So what's your advice?
Yeah.
To deal with these families?
Okay, since everybody might not have been able to hear that, he says he deals with a lot of situations where patient comes in and they're so devastated, the likelihood of recovery is minuscule, right? And he would have a tendency to counsel them for comfort care, and instead the family wants full court press. And what do you do about it? Well, I'll tell you what we did about it in my system. What we did about it in my system is we usually didn't do a whole lot for a day or two. You just kind of write it out and do the obvious next thing. But we don't go ahead to the trach and the peg and everything else instantly, right? And then we would usually call an ethics consult or a palliative medicine consult. And the reason you do that is the palliative medicine approach is really, what do you really think this person would have wanted? Not you, but them. What do you really think they would have wanted? And if you can get to the bottom of that, a lot of times it becomes much simpler, and they say, well, there's no way in the world he would want this. And then you say, well, we want to honor his wishes as much as possible. But sometimes it's intractable. I remember one case where this guy was in the ICU and he'd gotten like 45 transfusions and he was getting nowhere. The surgeons really thought there's no way he's ever going to make it. And we even called in the priest. He was Catholic. We called in the priest, and the priest talked to him and said, there's nothing in the Catholic doctrine that prevents us from saying, we've done enough now. It's okay to just stop. And the family still didn't want to do it. So that became a really, really tough one. Sometimes you have to call in the law. You have to get a judgment. I mean, it's terrible. Fortunately, those are pretty rare. And I was involved in other cases where different family members were in disagreement, and we said basically, well, let's just be conservative for the next day or two and see how things go. And usually it worked itself out. It was amazing how often it worked itself out. I had one where it was a new wife, and grown children and a new wife. She'd only been married for 6 months, and he had a big MI, and he wasn't making any progress. And the ICU team said he's not going to make any progress. He's going nowhere. But we didn't push it. We just kind of talked to her, and we reinforced that this really isn't about what you want. It's really about what do we think they really wanted? Autonomy was the word I was stuck on earlier for you bioethicists in here. And many people think autonomy is the number one thing. It isn't. It isn't the only thing, but it's kind of become the big thing. Anyway, um, we just said that to her. We said, this isn't about you. It's really about what do you think he would have wanted? And her response was, we've only been married 6 months. And it's like, that's not good enough, you know. And by the third day, she said, well, I think the kids are right. And so we went to comfort care. He passed away a day or two later. But you're talking about a really tough situation, and it's not easy. And so my response would get the team involved, like get the ethics consult or the palliative medicine team involved. They can be helpful. Uh, if there's a trusted family doc who knows this patient forever, get them involved. If they're a religious family, get the pastor involved. So yeah, get some reinforcements. So it's not you pitting yourself as the hard-nosed doctor who wants to put somebody else in that bed. I was actually accused of that once. I was a neuroconsultant, and I said, we're making no progress, and I think it's time to go to transition care. And she said, you're only doing that because he doesn't have any insurance. And I said, I never have any idea who has what insurance. But she probably went to her grave saying that that young whippersnapper uppity doctor killed my son, you know, which obviously not true. But is that good enough for you?
Yeah.
Okay, so moving on. I skipped ahead to this one because this is Ira Byock, and I'm not even sure how active he is anymore, but he wrote some good stuff, and I love this book, The 4 Things That Matter the Most. Asking for forgiveness, offering heartfelt thanks, and offering sentiments of love. Ira Byock tells a story about a very stoic Nebraska farmer who called all his kids in for dinner. And he said, I read this book by this death doctor, and I wanted you all to come in. If I've injured you in any way, I'm sorry. And I don't hold anything against any of you. I forgive you all. And thank you. I really appreciate all of you. And I love you. And pass the potatoes. So he read the book and he did the 4 things. But you can put those in your document, you know, if you want. You can say, I know I was hard on Sandy when she wouldn't go to college. And I was wrong, and Sandy's been successful, and that's good. I mean, you can put that kind of thing in your 5 things. Okay. Now, the reason I put this in here is dementia, in some ways, is just slow death, right? It's the trajectory is very similar to many slow-growing cancers, right? You know you're losing ground. You know you're not going to win. You hope you'll get a setback. But the literature between dementia and death counseling can be somewhat helpful and similar. Now we can back up one slide. Just wanted to talk about the difference between competence and decisional capacity. And this is so frequently confused in language that people talk about. They say, Daddy's not competent. Well, Daddy may not be competent to supervise the merger of his company with another company, right? That's one level. But he may be extremely decisional insofar as, I'm sick of lime jello. Please quit putting that on my table, you know? Or, I don't like that one nurse because I think she's rude. Okay, that's okay. And if he really thinks she's rude, maybe you need to talk to the head nurse, and maybe you get a reassignment. So decisional capacity at some level is present long after competence may be lost. And competence is important, but it's a legal issue. There are many scams that are foisted on slightly demented people who are getting more demented. My parents were never diagnosed as having dementia, but I was convinced that both of them had at least MCI and maybe early stage dementia. And I came to my dad. He lived a couple hours away. I came down. He said, "Man, I got the coolest stuff on my phone." And I said, "Really? What'd you get?" He said, "Well, I got call waiting, and I got conferencing, and I got an answering machine function." And I said, "Dad, you don't need any of that stuff." And he said, "Wow, yeah, I guess not." I said, "I call you, my brother calls you, and your brother calls you, and anybody else calls you if you're busy, they'll call back. You don't need any of that stuff." So I called the phone company and I said, "Cancel all that garbage, and you need to give him a refund because he has some cognitive impairment and you suckered him into buying all this stuff." They wouldn't back down, right? They claimed there was no proof that he had mental incompetence, and he had entered into the judgment of buying it. So anyway, scams are very common. You got to be careful for them. We're nearing the end of this, so feel free to butt in. 5 wishes I went over. Okay, this is the summary slide. It's a progressive process with variable speed. And the second part is just as important. It can vary from day to day or within a single day. And this is very common. You'll talk to somebody and they make pretty good sense, and then a few minutes later they say something that makes no sense whatsoever. And I've seen this a number of times. I won't give specific examples, but I can just say, well, here's an example. I know a patient who they wouldn't let her cat come into the nursing home, right? So one of the daughters bought her a mechanical cat, right? It purrs, it has soft fur. And there are times when she is convinced that that's a real cat. She tries to feed the cat, right? Now she's going to ruin the cat. She's going to. So, and yet, sometimes you're talking to her and she says, "Yeah, I know, she's got a chip and some batteries and some kind of mechanical stuff." So even in that same day, she varies from, she knows it's mechanical to, "I really think that's my cat." So I put loose ends. Don't immediately assume it's dementia, and if in question, escalate it. Get a dementia specialist to look at them. But rule out all the things you can fix. Look at the medicine list. See how they're sleeping. Any infections, UTIs are famous. My mom used to be pretty sensible, except when she got her UTIs. And then she'd be, all kinds of crazy stuff. And then she'd get the UTI cleared up, and she was pretty sensible again. So, and you must be in it with the family for the long run, and keep spiritual issues central. Now, some people will say we need to pray that God will cure the dementia, and I do believe in divine healing. I know that God does that. How many of you have heard of Forrest Frank and He's Got My Back? Anybody familiar with it? Yeah, he's a contemporary Christian music guy, and he said he actually fractured his spine, and they had a healing service, and he's walking. He's okay, and he says it was divine healing. Okay, there's more to that story, but the point is, divine healing does still occur, but there's a lot more things about the wellness of this person than the physical healing, right? And we want to keep those things in mind. Are they tuned into the Lord? Palliative medicine used to be very good about physical, psychological, social, and spiritual. It was like a 4-pronged thing. A lot of them don't emphasize the spiritual, and some of them actively argue against the spiritual, saying, "We're doctors, we're nurses, we don't deal with that." But you can choose to keep it in the mix. And here's my last slide of the night. The word vulnerable came up earlier today. I think it was Dr. Mitchell. And this quote has been attributed to different people. Mahatma Gandhi, Pearl S. Buck, Hubert Humphrey, and others, but variations on it. A society can be judged by its treatment of its most vulnerable. There actually is a true quote by Pearl S. Buck that says, "The test of a civilization is the way it takes care of its helpless members." And interestingly, I saw this a few months back. They found some bones of some person they dated back like 4000 BC who had clearly had their broken femur reset. Okay? So even in that society way back then, and you think if this was an agrarian or a hunter-gatherer group of people, it doesn't matter. They refused to let that person with a broken femur just die. They reset the bone. Okay? Jesus reached everyone, especially the marginalized. And as Dr. Mitchell said several times today, our disability or our dementia in no way takes away the fact that we are God imagers. So the question that I would ask is, how can you help? And there is a donation box back there. Dr. Ritchie didn't ask me to make this pitch, but on your way out, you can think about that. But respite care, that group, we remember, is always looking for volunteers to help out with respite care. And there are other similar organizations. Or in your own family, are you being the kind of help for your loved ones? One of the most useless things that you can say to somebody who has a demented family member is, "I got your back, I'm praying for you. If you ever need anything, give me a call." That's pretty worthless, isn't it? You could say instead, "This is a tough situation. Let me pray with you right now." Michael W. Smith, if you remember that song, "Let us pray, let us pray." Don't say you're going to pray, but actually stop and pray with him. Or secondly, you can say, "Here's my number, and I am absolutely sincere. I like mowing lawns, and I like cooking. And anytime you need your lawn mowed or cooking, I want you to call me. And if you don't call me next week, I'll call you." Okay? And when my wife died, I had a good friend who took me aside and he said, "A lot of people say stuff, but here's my number, and I want you to call." And Jack is not a saint, but he is a godly man. So I guess he's a saint, and he's a saint. He's a child of God. I call him 3 or 4 times in the first month, and we just stop and go to McDonald's or Dairy Queen, just get a cup of coffee and just talk for a little while. But just being available to the family and really being available and not lip service and not. I've reached out to one, there's a demented man in our church, and he's the sweetest, godly man, and he's just started losing it in the last year. And I called his wife like 5 or 6 times trying. She thought she didn't recognize the number and she didn't answer. I finally caught her at church and I said, "I've been calling you, and we want to get together with you." And she said, "I didn't recognize the number." I said, "Here it is, Bob, and I'm with Tammy, and this is our number, and we want to get together with you next week. What day is good for you?" That worked. Okay. But my 5 phone calls before that didn't work. Time for questions. Any questions? I know it's late. You've been here a long time. Thank you. Yes.
I have 2 questions.
Yes.
All right. This one, pardon my ignorance if this is a dumb question, but do novel cognitive pursuits actually have some benefit? Have you seen it actually be helpful, and did you ever recommend it?
One, it's not a stupid question. And as they say, the only stupid question is the one you don't ask when you should have. 2, the evidence is not compelling, but there are some commercial systems that claim that if you do their system, you'll actually gain some ground. And I play word search, Sudoku, and solitaire almost every day. I think, what can it hurt? It's a lot better than following the NBA standings. Although if someone was serious about following the NBA standings and they really worked at it, maybe that would help them too. So I don't know. I don't think there's a good answer on that yet. But I think, what can it hurt? And if it keeps them engaged in life, there is evidence that staying engaged in life is important. So yeah. Other questions? Up front?
My dad has no filter.
Yeah.
It's super embarrassing.
Yeah.
Is there anything I can do when he points and says something bad about somebody 2 feet away from me? It just, oh, it's okay, he's got dementia. I don't want to say, I don't say stuff like that. I try to redirect her.
Yeah. What she said was, her father says embarrassing, inappropriate things to people, and she doesn't know what to do about it. He has no filter. Having no filter is a part of a lot of dementias, especially frontotemporal dementia. But a lot of, my mom used to weigh, she was about 5'7", she weighed 200 pounds. And then as she got sick and older, she lost a lot of weight. She got down to about 100 pounds. She actually looked pretty good for her height and everything. She'd see somebody go by who was a little fat, and she'd say, "That's a fat person."
Exactly.
And I'm like, don't do that. But no, there's not a lot you can do about it. And it's like, my brother who had frontotemporal dementia was saying embarrassing things too. But yeah, you think about it, a lot of us say unfiltered things from time to time. So when you get demented, it's more so. But yes.
One option, I think, I can have all these wonderful ideas, but if you ever create a business card and hand it to that person who's embarrassed, and so it doesn't dishonor your father, but the person then knows that it's my father. It's a way of communicating in a way that's informative, and the other person leaves without, like, okay, I totally understand, but it's not disowned, it's not honoring your father.
That's a great idea. Did everybody hear that? He says, give a card, have cards pre-made that just say, my father has dementia. I'm sorry for the inconvenience or whatever. Just hand it to him. And that's wonderful. And it does honor your father, and you can do it kind of non-verbally. You slip it to him, and no big deal. Wonderful idea. My wife says to me sometimes, "Bob, you're too bold." And I say, well, back here and then up here.
This is more of an observation than a question. I have two aging parents. They're in their 80s. Um, they'll get things from their doctor's offices. This is for us to consider as doctors, and it's a check-in for the next appointment. And it feels like it's 20 pages long, and they get so confused because they don't know how to use the cell phone in the first place. And then once they get started, by the time it's over, I'm at the house going, "Dad, are you depressed lately?" And so I'm going through. I mean, I think that has to be redone. That has to be reconsidered. That's not helpful for the demented and the elderly. And the second thing, probably nobody is here, that the medications from pharmacies. If my mom and dad go to more than one doctor, my dad was on a beta blocker for months, two beta blockers for months before we realized dad's on two beta blockers. It's good thing he's got a pacemaker. But whatever the doctor gives, he brings home. He never questions. He puts it in his little pill box, and the same for mom. So I think our aging population, somehow we have to be better with this computer stuff they get at home, and then also the medications, because that's a big problem.
Yeah. Did everybody hear that? Valid observation. I went to my doctor. I'm a physician. I've been licensed for a long time. I have very, very mild type 2 diabetes, very well controlled. Every time I go, I get a 4-page handout on what to expect with diabetes. And, it's kind of garbage. But the beauty in your situation is the younger adult child with a little knowledge can help a lot. And if I were that doctor and you sent me a note and you said, let's quit doing these stupid things because they don't help dad. And by the way, did you know he's on 2 different beta blockers? I would really appreciate it. But it's not, it, you can get into the whole politics of, if you check off enough boxes, then you can bill for the right amount of money and you can keep your clinic open and keep the lights on and pay for your CNAs and pay for your malpractice insurance. And so we just keep checking off those boxes. Was there another hand? Yes.
It's not a question, just an observation. 46-year pastor, we took care of our moms till they passed away from dementia. All any of us have is today. That's all we've got. I can't fix it, but if there could be a moment of joy, if there's one bright moment that made it worth it. What? The ambulance attendant stopped for mom one day, and we were trying to get her loaded, and he said, what do you call her? What do you call her? Well, Granny or Aunt Jolly. I said, I like Aunt Jolly. He was like, Aunt Jolly, here's what we're going to do. We're just going to throw you out of the truck like an old sack of taters and take you for a ride.
She laughed.
Mom loved it.
Yeah, she laughed. Yeah. Sometimes. Yeah.
Spoke her language.
Yeah.
Did it fix anything?
No.
It didn't have to.
No, but it's just like Mrs. Bray said, when some old lady at the nursing home comes up to her and says, you're a good daughter.
Yes.
It's helpful. That's helpful. Yes.
Just that, responding to that, theAFTD.org, so for FTD, they actually have the cards pre-made that happens to be what you are interested in. It will say frontotemporal dementia on it. I just asked them for my husband. So my question is, how do you encourage the wife who's been married to this person for a long time, now that they have cognitive impairment and cannot see it, and they maybe want medical intervention that they did not want in the past? Is it okay to honor who they were over who they are now?
Could you repeat that? I didn't follow the whole question completely.
Would you encourage them?
Would I encourage the braces? Would I encourage?
But my husband has FTD, and one of my daughters was really, I felt it was such a wise moment for me when my daughter said, Mom, it is okay to honor who Dad has always been over who he is right now.
Yeah.
And that was really helpful to me, but there's still some guilt when he maybe wants me to do things that they're not going to have. They are like the braces, right? This is not going to be helpful.
Yeah.
And they only increase the agony, as you were talking about before, but increase the length of duration of difficulty.
Well, it's a tough situation. And as a doctor, for instance, many years ago, doctors would kind of tell people, this is what you got to do, right? And then we went through this phase where, what do you want to do? And I don't think either approach is really right. It should be, what makes pretty good sense? What would really fit here? And then it's more complicated when they have the dementia. But do you have to go with their every whim just because they ask for it? No, sometimes you need a family discussion, and like you got your daughter involved, that was very helpful. Um, it's tough to know sometimes. Uh, my mom got to the stage where she demanded $10 from my dad every week to go to the thrift shop. She didn't need any of that garbage, but she was spending $10, and I didn't interfere because I thought $10 a week, who cares, it's like not a big deal. I'll give you the $10 if you want. Was there one other hint? Yes.
My mother seems to be experiencing a lot of issues with night and day
Yeah.
and not understanding clocks to know what time it is.
Yeah.
And I've got her one of those Alzheimer's clocks, that has AM and PM and the date and the time and all that. But we just don't really know what to do. I mean, sometimes she just doesn't have any concept of time
Right.
anymore.
That's a classic symptom of various dementias, not just Alzheimer's. You,
A real diagnosis. We're still working on it.
yeah.
Like we know she's got dementia, but we don't have a clear thing about Alzheimer's yet. We did a blood test, but
Well, that's a separate discussion. Are the blood tests even appropriate? And the answer is the American Academy of Neurology says they're really not appropriate at this point in time unless you're working at a specialty dementia clinic with dedicated guys, because it's really easy to throw a brand new test at somebody and say, you're in, you're out, and it's not that simple. But back to your question, you can do some obvious things like you could even get her curtains in the house on an electric timer, and every morning at 8 a.m. they go wide open, and so do the blinds, and at 9 p.m. they all close. Things like that, or you could do it yourself. Yeah, it's not easy, but the time dissociation problem is very common. Reorienting them. It's like Mrs. Bray said, her aunt called at 3 in the morning and says, nobody's down here to feed me breakfast. Yeah, right, okay.
Also call at 3 a.m. and ask what time it is. My wife will tell her 3 a.m. She'll say, well, my clock says 3:15. Big digital clock on her.
Yeah. Some of these things, I have a dog, a small dog, and we're walking, and he thinks he knows where we're going, and he'll just spurt off like, yeah, we're taking the turn here because we're not going that way tonight. And so I just give a gentle tug, and we bring him back, and we're going this way tonight. And I often think, that's me, man. The Lord is trying to move me in a given direction, and I think He knows. I think I know where He wants me to go. Well, we run into the same thing with our demented loved ones. Is sometimes they want things that don't make any sense, and you just have to be gentle and try to bring them back if you can.